Thanks everyone for joining us on a Tuesday night. I know a lot of you are still getting off work. Maybe you're in the car listening. So I'll try to read the screen to you too, so you don't have to read every bullet point. But tonight we're going to talk about mastering pediatric zirconia crowns. Earlier this year, we did one on introductory to zirconia, where we kind of just touched on the basics. And then tonight, we're not all going to master zirconia in 45 minutes, but we're going to try to go over some really important topics and really important things to try to think about approaching zirconia a little bit differently, so that it hopefully makes it a little bit easier for you at your office or at your clinic, or for residents when you go back to residency. So we'll get started here. Let me click on my screen. Hopefully it'll go. There we go. So that's me. I'm Matt Lucero. I am a board-certified pediatric dentist. I currently practice in Denver, Colorado. I previously practiced in Austin for a while, but we've been in Denver since 2021 now. If any of you are interested, you can also follow me on Instagram. I don't post all the time, but whenever something cool happens, or if I have a cool case that I want to document and show other people, I'll put it up on there. So if you're so inclined, you can follow me at Dr. Matt in Denver there on Instagram. A little quick history about me. I went to dental school in that terrible place that you can see in the photo there, Fort Lauderdale, Florida, at Nova Southeastern University. Spent a great 4 years there, met lots of good friends. Some of you may know Dr. Dave Evans. He does some of these webinars and some workshops as well with New Smile. So I met him there. He was a classmate of mine. So really good time in Fort Lauderdale for dental school. At the time when I finished, I did an AGD in San Antonio at the VA hospital. My plan was to be like a kind of like Swiss Army knife general dentist that could do everything, full mouth rehabs and implants and, perio surgeries and all the above. And then I got out of residency and realized I didn't like doing any of that stuff. So I ended up working in a public health clinic in Georgetown, Texas, called Lone Star Circle of Care, where I saw a lot of kiddos, a lot of underserved kids, and that really motivated me to work with kids. And so I went back to school after 5 years of practicing at Oregon Health and Science University in Portland, Oregon. Really love Portland, Oregon a lot. It's a great place. We actually have a workshop coming up in Newburgh, which is just outside of Portland, if any of you guys like Pinot. But that's a really great place to visit, especially in the summertime. Winters were a little long and gray, so we ended up moving back to Austin and then eventually ended up here in Denver. But that's kind of my story there. Quick disclosure tonight, New Smile does provide financial support for these webinars. They also send me goodies in the mail that I get to tinker with and take photos of and document for these types of lectures and workshops. So there are some photos in this lecture tonight that are other docs pictures, and I'll try to cite those when I use them. So tonight's objectives. We're going to talk about when full coverage restorations are appropriate. I think it's always important to go over that because that's really what backs us up in our decision-making process. We're going to revisit anatomy, which doesn't sound like mastering anything if we're going to go back to dental anatomy. But I think that's going to be really important because that's how I visualize my endpoint, and that's how I visualize how I'm trying to finish the case. So I work back to front. So I try to picture what my endpoint is, and then I work from there to get to that point. I'm going to demonstrate prep technique. We're going to talk about the IFU prep technique for posterior zirconia, but I'm also going to give you my technique for prepping anterior and posterior zirconia. We're going to discuss treatment planning. That's going to be the whole end of this lecture. We're going to go through a whole treatment plan and considerations for severe early childhood caries. And then for that same patient, we're going to work through the entire general anesthesia case from start to finish. So I'll show you my entire process for zirconia from the very start to the very finish. So here are those guidelines I talked about. This is very basic stuff for a lot of us, but it's good to remember and good to remind ourselves what these are. That way, if anyone questions our decision-making, or if we're trying to work through our own decision-making, we have reasons for doing what we're doing. So full coronal restorations for caries primary teeth may be indicated when caries is present on multiple surfaces. That's an easy one. That's kind of the giveaway for all of us. Interproximal caries, a lot of us do crowns. I do typically for any interproximal caries or MOs, DOs, DFLs, MFLs, any of that. If the incisal edge is involved, that one for me is an always. There aren't very many MIFLs and DIFLs walking around that we see successful day to day. And if they are successful, they're kind of quasi strip crowns anyway because they're bonded to so much of the tooth. If there's extensive cervical decalcification, and the more I practice and the more I pay attention to this, the more I see it. If you try to do an MO or a DO on a tooth with cervical decalcification, where do you end your box, right? You drop your box and you extend it and you're still in decalcified tooth structure. And the more you extend, you never get to the end of it, right? So We can't bond to that very well, so that's a good indication for a full coverage restoration. If pulp therapy is indicated, that's another always for me. If you spend enough time on the internet, you'll find people telling you that they did an MO in pulp or DO in pulp, and maybe it works, maybe it doesn't. But I know crowns work, so that's why I go with crowns whenever there's pulp therapy. If the caries is minor but oral hygiene is poor, and then also if the child's behavior makes moisture control very difficult. And those last two, I call those like the Hall crown guidelines, because that's typically when we're doing a Hall crown. If the caries is minor and you have an uncooperative little one, well, let's pop a Hall crown on it. So I think these are always good to keep in the back of our minds whenever we're doing full coverage restorations or pediatric dentistry in general. I want to start with talking about composite strip crowns because we're going to talk about zirconia, and so I want to first talk about this because this is a lot of our alternative for aesthetic anterior restorations. And the reason these aren't the ideal treatment is because there's so many shortcomings. We have incisal wear, you have oral habits that a lot of these kiddos have. You're prone to recurrent caries, continued demineralization, especially at like the gingival third, the cervical third. And then you have challenges with just placing these in general, which, is isolation, bleeding control. If we hit that gingiva, we have to stop that bleeding before we can start etching. You etch and then you rinse it off and now the blood comes back. So it gets really difficult to do a really well isolated strip crown. And I like this photo here. This was one from Dr. Larry Johnson. It really exemplifies kind of what happens with these. And this is a kiddo that was treated twice with strip crowns and they're still in this condition. So if we can do a restoration that's going to last longer and be more predictable, I think that's always the best bet. So here's an article that kind of backs that up. This one's out of Bangkok, Thailand, actually. But they found that ultimately strip crowns were deficient in function, especially with longer follow-up periods. And I think that's what a lot of us experience too, is initially things look really great. At 6 months, 12 months, 18 months, and as things go on, you start seeing more and more breakdown and more wear, more staining, more recurrent caries, all that stuff. So they found specifically in this article that 52.8% of the resin strip crowns were unacceptable in function, which that's quite a few. If we're looking at 50% success, that's not something that we're typically aiming for. And this is a photo from that article, and you can see these are the same things we see every day, right? Chipped, fractured, recurrent caries, all the things that we don't want to see with the strip crown. And here's, conversely, here's an article talking about zirconia crowns and more successful follow-ups. This one's from University of Washington. This was back in 2019. And they found, with aesthetic characteristics and high survival probabilities, zirconia crowns present a suitable alternative. Suitable, I think it's more than suitable. I think it's a good alternative because they found 12-month survival rates at 93%, 24-month at 85%, and then 36-month at 76%. And those percentages to me even seem a little bit low. I see, and this is anecdotal, but I see higher success rates typically with zirconia crowns than especially that 36-month survival rate. Here's one more study. I'm not going to go too deep into studies today, but this will be my last one, just to kind of to drive home the point that zirconia is a successful restoration. This one's out of San Antonio. Dr. Donnelly down there. This is the 3-year, 36-month follow-up on this study. There was a 24-month as well, and I believe there should be a 48-month. I just haven't seen it yet, but there's some attrition also, which is why the numbers are so low. But they have 18 new Smile ZR crowns and 17 stainless steel crowns that they evaluated. And there were no failures of the new Smile ZR crown at the 36-month evaluation. And their conclusion was results indicate that new Smile ZR primary crowns perform similarly to an established stainless steel primary molar crown for restoration of primary molar teeth. And I found this little blurb in the study to be pretty interesting. It says the only significant difference, so there was no significant difference between the zirconia and the stainless steel success-wise, but the only significant difference they found was parent satisfaction, obviously with aesthetics, and gingival health, with the zirconia crowns having healthy adjacent gingiva. And you can see in the photo there, you got red kind of puffy gingiva around those stainless steel crowns, and then you have some nice tight pink gingiva right around that zirconia crown. And that just, shows the biocompatibility of zirconia versus stainless steel. So, in all, they're a better option, if you look at those factors as well. So how do we get here? And this is going to be kind of the subject of our talk tonight. Like, how do we get to a well-fitting crown with optimal biologic properties that fits the tooth that we're trying to restore? How do we get to this point? And that's what we're going to talk about tonight. So here's a tooth. This is a photo from another study that I borrowed. This one's out of China. This one was pretty cool. They took 3D imaging of primary incisor teeth and mapped out the pulps. And I thought this was a really, really important thing to show when we're talking about prepping these zirconia crowns, because one of the concerns a lot of people have is, are we going to need to do a pulpotomy, right? And that's, people think, just because we're doing zirconia, automatically we have to go into the pulp because this prep is so heavy and we're going to have to do something with the pulp. And that's not necessarily true unless there's decay to the pulp. Obviously then we do a pulpotomy, but not strictly because we're doing zirconia. So I'll walk you through my technique for doing these preps here. You're going to do some incisal reduction, 1 to 1.5 millimeters, and that's all dependent upon the patient, their occlusion, if they have wear, if they're in a crossbite, et cetera. So those are things that we can kind of determine ourselves clinically. So incisal reduction, then we're going to do interproximal reduction. And those of you who were with me with the webinar earlier this year, or if you've gone to a New Smile workshop, we talk about doing interproximal slices, leaving a shoulder, and then going back and removing that shoulder. And a lot of people ask, like, do you guys do that prep? And I don't. And this is what I do instead. So I imagine my burr working back to front, right? So we're trying to get to our end point. How do we get there? So I take a pointed diamond burr, and I picture that burr coming out right under that convexity of the tooth, because primary teeth have a lot of convexity. So all of that extra tooth structure that's hanging off to the side, we can remove all of that, no problem, because we've got a lot of space to work with. And so I'm picturing the tip of my burr coming out just below that interproximally. And those are where I try to aim my interproximal slices. And so I'll take my burr, and I want to hold that burr vertically or parallel with the long axis of the tooth, because that burr has a built-in taper, right? So we don't need to lean the burr over and take any more tooth structure off than what the burr is going to do on its own. So hold that burr vertically, have the tip of that burr work its way out through the bottom of that convexity, and that should be all of the interproximal reduction you need to do. And it makes it really, really simple. So if we can picture, this is what our prep should look like, and it has the same taper as that burr. This is what it should look like within the crown itself once we restore the tooth. And then this is what our final restoration should look like. So you can see where those slices were is exactly where that margin is, and that should be a very well-fitting crown. And then from the proximal view, it's a little harder to see this in the mouth, so don't have as many examples, but same study, took some photos from that study that show where the pulp is. We're going to do our incisal reduction, and we're going to reduce the facial and the lingual. And on the lingual, you can notice that we're really just getting rid of the cingulum. So if it's a big cingulum, get rid of the bigger cingulum. If it's a small cingulum, get rid of the smaller cingulum. And then we're going to finish that prep, and that should be what our prepped tooth looks like within the crown. Obviously, we're going to round everything off. We're not going to leave it, sharp angles or anything like that, but we're going to round everything off, and that should give us plenty of reduction to fit within the crown. And when we're doing these, we just picture all we're trying to do is, if this is our fixed crown, we can't change the dimensions of that crown. We're trying to get the tooth to fit within that crown and have some passivity, because zirconia can't expand. So we don't want to put an under prepped tooth within it, because you're going to expand the crown and we're going to fracture it. So you want to make sure that that tooth just fits within the confines of that crown, get a little bit of movement, and that's all we need. Then we're done. So if you think of it from the end point to the start, it makes it a little bit easier. So when we're prepping these, we're going to end up subgingivally. We're going to create some bleeding. And because we just talked about it's a passive crown, we're counting on our cement 100% to retain this crown. So we can't have any contamination, which is going to hurt our bond strength and hurt our retention. We also don't want bleeding on the tooth, because these crowns are translucent. And if you cement a crown, a translucent crown on a bloody surface, you're going to get some really, unesthetic staining coming through that. So we need to control the hemorrhage somehow. So there's a few ways to do that. One is pressure, or move to another treatment area. So prep your anteriors first, do your posteriors, then come back. The one thing I don't like about pressure is that you're going to squeeze the sulcus against the tooth potentially. Then you're going to have to reopen that sulcus back up to seat the crown and potentially start the bleeding over again. So that's my one knock against pressure. I think moving to another treatment area and coming back is a good way to do it. I'm totally fine with that, but I think the pressure does kind of hurt you at the end when you're trying to cement. Ferric sulfate's another option. Downside to ferric sulfate, of course, is it's going to stain the gingiva, and you're going to have some dark staining, at least post-operatively initially, and parents don't tend to like that. This is what I typically do: local anesthetic to blanch the gingiva. So I'll take my local and I'll put it in the papilla right around the teeth that I'm trying to restore. Just before I cement, I'll blanch the papilla. I'm not so much worried about the epinephrine as I am just blanching everything and getting the bleeding to slow down temporarily. That buys me enough time to seat that crown before the blood reaches the tooth surface again. Or you can do viscous stack clear. Does similar type of thing to ferric sulfate, just without that staining on the gingival margin. So any of those work really well. Pressure, just keep in mind that you're going to have to reopen that sulcus if you're holding it tightly against the tooth. And then what do we use for cementation? There's lots of options. These are probably the most popular options that most of us use. Reliax and Fujisem 2 are basically the same thing. They're resin modified glass ionomer, just made by different brands. And you can see the retention is about the same with both of these. Downside to these is they're self-curing, so you're going to have to wait while that cement sets up. And with bleeding and things like that, you just want to be careful while you're waiting, because it takes a minute or two for that to set up. Biosem is what I use typically. The benefits of Biosem is that it's a dual cure, so I can light cure or tack cure these crowns into place, and you'll see that when we do the case later tonight. Benefit also is that it's bioactive, and that you're going to get a bit more retention. So you're going to get 20 kilograms retention versus that 15 that you get with a resin modified glass ionomer. With a straight glass ionomer like Keytac Sem, I know a lot of us like Keytac Sem for stainless steel crowns, space maintainers, things like that. Biggest downside is that it doesn't have quite as much retention. Since it's good, it's good for stainless steel because we're getting secondary retention typically, right? We're getting a little bit of a snap that's helping hold those on. We're not getting that with zirconia. So if we're counting on cement 100%, we want the strongest cement that we can get. And typically, straight glass ionomers aren't going to provide that for us. So I do not suggest using a glass ionomer cement. I know there's some of us that do it. I have a buddy that's told me he uses it and it works just fine. So, just be comfortable with what you're using and know the shortcomings of each of these products. So let's talk about the posterior express prep. This is the prep that's in the IFUs. And if you go to a New Smile workshop and we do the hands-on, this is what we go over. And mainly this is to keep everybody on the same page, because, if you make a mistake, you can go back a step and say, okay, I must have done something at this stage that I can do differently. And then you can adjust things. Whereas if you're just doing the prep that I described to you earlier, you get to the end, something doesn't fit. Okay, well, now what do we need to fix? So let's go through these, and then we'll talk about my prep technique for posterior as well that simplifies it a little bit. So here's the express prep technique all together. They have PDFs of this with New Smile. So if you want a copy of this, you can send an email and they'll shoot you over a PDF of this whole copy here. But in general, there's 3 burrs that we use for the prep. There's a thicker, coarse diamond burr, a football diamond burr, and then a thinner, less coarse diamond that we use for the subgingival portion of the prep. So step 1 is going to be getting rid of the buccal and lingual cusps all the way down to the central groove. So you're basically just kind of cutting everything down to the central groove, and then you're going to use the tip of that football burr to recreate the central groove. On the intaglio of these crowns, you'll notice, of the posterior crowns at least, you'll notice that it follows the intaglio follows kind of the central groove of the tooth. So you'll have this kind of shape on the inside of these crowns. So you want to recreate that central groove a little bit. There's the central groove right there. So we'll keep on moving. Then we're going to reduce the buccal and lingual cusps. We're going to basically create a bevel on the buccal and lingual cusps. So we're going to kind of round everything out by creating a bevel. Then we'll do some depth cuts. We're going to take that thicker, coarse diamond burr I talked to you about, and we can create as many depth cuts or as few depth cuts as you want. Do the full depth of that burr. You can see the thicker part is about 1 millimeter, and that gets you that 1 millimeter circumferential reduction once we get rid of these depth cuts here later on. Then we'll do an interproximal slice, which is the full depth of that burr, and you can see you're also getting another millimeter reduction interproximally. Now, this part I like to talk about, and I think this is really important when I was talking about keeping the burr vertical and using the taper of the burr for your reduction. What people tend to do is they do this thing where they think they need to cut more tooth off, and you end up creating this kind of over-tapered prep, and that brings pulp horns into play, especially like lower first molars or upper first molars where those mesial pulp horns are a little bit longer. If you lean that thing heavily in from the mesial, you run the risk of doing this and nicking the tip of that pulp horn. And I think when people talk about doing pulp therapy with zirconia, this is one of the things that happens is people get a little bit heavy-handed with the prep because they think they need to cut more tooth off, and they end up hitting the pulp. And that's when you start seeing those abscesses that are unexplained. And it's probably just because people are nicking the pulp horn. So you want to make sure you're keeping that burr vertical. That's really, really important. And so rather than orienting it like this, we're going to keep it vertical and let the taper of the burr do the work for us. So at this stage, once we've done those interproximal slices, keeping that burr vertical, then we're going to connect all those depth cuts together, and it's going to create a shoulder, which is going to give us the opportunity to do a super gingival try-in. And this is basically just to make sure everything we've done to this point is appropriate. We've done enough reduction. Our crown is fitting, and we got a little bit of movement. We don't need it spinning like a top, but we want it sitting on that tooth and having just a little bit of passivity, so you know that it's not binding, and you know that you're not going to expand that crown out and fracture it. So now that we know that's good, we're going to get rid of that shoulder, and we're going to create just a normal feather edge margin like we do on every other SSC that we do. The one thing I want to caution you on, this is where people run into problems under reducing. You don't get rid of that full shoulder, or you leave a little bit, and you can see in that area that I shaded, you see that little bit of I guess, height of contour that's left right at the gingival margin. And so when you go to seat that crown, it might seat on one side and kick up on the other, or it might rock, or it might just not seat at all. And that's usually what the problem is in that gingival or cervical third of your prep, you've under reduced. So the crown goes all the way down and then it hits a dead end, right? And now people start, then people start panicking, and they start leaning the burr into the tooth and making the incisal or the occlusal third narrower, when really where they need to focus is down here and narrowing the tooth that way so that the crown can seat the rest of the way. Then you'll do your subgingival try-in, make sure that that crown is still a little bit mobile on the tooth, and then you can cement. Control your bleeding, then cement. But you can see when you're going subgingival, you have to take care of the soft tissue. That's really important. So when we're thinking about controlling bleeding, it's not just stopping the bleeding once it starts, it's preventing it from being too heavy in the beginning. So taking care of your tissue, not blowing through the papilla, not being too aggressive with your burr, all those things play into bleeding control. And it's really important to keep that in mind from the very start so that you're not trying to make up for problems later on. And so here's the way I prep. So same thing that I showed you with the incisor. I'm not using all three of those burrs. I'm using two at the most. And I'm using really like a thinner, a thick diamond burr with a really thin pointy tip. That's kind of my burr of choice. And so I'll do my occlusal reduction. This with a molar or a posterior tooth, you want to do a little bit more, 1.5 to 2 millimeters or so. And then I'm going to do the exact same thing interproximally that I did with the anterior teeth. I'm going to imagine my burr dropping through just below that height of contour, that convexity of the interproximal tooth. We're going to drop right through that into that area below the height of contour. And then we're just going to do a slice all the way through and get rid of that entire height of contour of the tooth. And then we're done. That's really it. That's where we want the margin of our crown to end. So that's where we want our prep to end, right? So we're thinking backwards we're thinking from the finish to the start. Same thing. There's our burr. There's our taper. We're just going to let the burr do the work. And then this is a proximal view. So that side on the right there that's shaded red, that's your buccal. So you're going to have buccal bulges on upper and lower first molar. So you have to keep that in mind. You're going to have to do a little bit more reduction in those areas, especially if it's a really big buccal bulge. But the same exact thing. We're going to take our 1.5 to 2 millimeters, and then we're going to do our buccal and our lingual reduction, same as we did for our incisor. But we're just going to keep in mind that the buccal might be a little bit bulkier on those first molars especially. There's our burr, same taper, same thing. So now that we've talked about the prep for anterior and posterior teeth, we're going to put that all together, and we're going to go through an entire case start to finish. I just did this case like 2 weeks ago. So I've been looking for one to document. So we documented the heck out of this thing. And then we'll have some questions probably at the end, because I'll walk you through my clinical thinking too. And then if you guys have questions on it, feel free to ask at the end here. So here's some patient info. This is a 2-year, 8-month-old little girl, unremarkable medical history, no allergies. Classic story, went to bed with the bottle. So now she's got some decay that we need to address. This mother is very aesthetically motivated. So we talked about all different options, ITR, ART, all the alphabet soup options. We talked about veneered SSCs. We talked about silver diamine fluoride. But this mom is not interested in anything that's going to discolor teeth. She's not interested in silver. She's not interested in posterior stainless steel crowns. None of these things, so she's aesthetics are the main motivator here. She wants things to be very pretty at the end. So obviously we settled on zirconia. She's a high caries risk kid. She has severe early childhood caries. And we're going to obviously be doing general anesthesia for this treatment. So here's her clinical presentation. And this is the part where people might be like, wait a second, we're going to be doing zirconia on these teeth. So I'll show you the intraoral shots too, but obviously we've got a big cavity on D there. We have some demineralization on the facials of E and F, got a little spot there on G, but here's the intraorals. So this might alleviate some of your concerns here. So if you look at the incisors, we have, moderate to large lingual decay on D, E, F, and G. We've got fairly large occlusal cavities on L and S. And then we have some smaller kind of just, run-of-the-mill OLs and occlusals on A, J, K, and T. So when I'm thinking through these types of cases, what I'm trying to think of, same thing, I'm trying to think of the endpoint, right? So this is a 2-year, 8-month-old little girl. I need these teeth to last another 5, 6 years potentially. So what do I want to do? And I do this enough. I do lots and lots of GA cases, and I've tried the more conservative routes on some of these, and I've seen this stuff fail. And so I'm a lot more prone to going for full coverage restorations, especially when they're 2 years old or 3 years old, because I just know how much longer these need to last. So for D, E, F, and G, we have zirconias, and then L and S, I'll show you the bite wings here in the radiographs. So you'll see how deep and how large those occlusals are on L and S. So we have zirconias planned for those two as well. So, that's my thinking when I'm thinking through these cases is how am I going to get this kid to the finish line? How are these teeth going to make it till natural exfoliation? And that's for me, conservative is making sure we don't have to do anything again. So here's my treatment. Here's my treatment plan, or actually my findings, I should say. We have occlusal caries, A, J, K, and T. We have facial and lingual caries with demineralization on D, E, F, and G. And I put the international numbers on here. A funny story. One time I did a lecture in Canada, and I got it through like an hour of the lecture, and finally someone very politely raised their hands and said, "I don't know what you're talking about because we don't use letters here." And so, the rest of the lecture I had to, count in my head to tell them which tooth I was talking about. So this is for my friends in Canada or anywhere outside of the United States. I got the other tooth numbers in there as well for you, so you know what I'm talking about. So occlusal caries, A, J, K, and T. Facial lingual caries on the upper incisors. Number D was that bigger one that I showed you. I was approaching the pulp, but we didn't have an exposure, so we're going to do indirect pulp cap there. And then we have some extensive occlusal caries undermining the lingual wall on L and S. So we have crowns planned for those as well. And then number S, if you look back, I'll show you real quick. You can see that mesial pulp horn's a little bit questionable, so we plan to pulpotomy for that tooth. So there's my treatment plan, what we just talked about. And here's my order of operations. So this is how I make these efficient. And most of my GA days we're doing between like 8 to 12 cases. And that's a typical day for me. They're long days, but we've got it worked out to where we're very efficient. My staff, my assistants are great. My anesthesiologist is incredible. But this is how I work through these cases in order to keep that sort of pace. So I use a dry shield. I usually will start on the left side. I'll do my left side composites. Then I'll prep my zirconia for L. And we'll cement that while we're still on the left side. We'll flip our dry shield. Then we'll do our right side composites. Then we'll do our pulpotomy for number S, and then we'll prep the zirconia crown. Then we'll prep D, E, F, and G. We'll do our indirect pulp cap. Then we'll cement D, E, F, and G, and then we'll cement number S, and then we'll finish up. So let's start working through this. This is my thought process. Same prep that I talked to you about on those images earlier. This is how I'm going to prep my molar. You can see I'm just dropping out just below the height of contour on the mesial and the distal. The mesial is the tricky side because it's not as convex as the distal is, so you just got to be careful over there. And you can see that big occlusal, that's where we're going to do our pulp. So we'll excavate all the caries after we do our initial prep. There's our burr again, showing you the taper of the burr, how we're going to use that. And same thing with our anterior. So we're going to do our incisal reduction. We're going to picture the tip of that burr coming right out below that height of contour mesially and distally. That should give us plenty of reduction, and then our prep should be finished, obviously with our facial and lingual reduction and buccal and lingual reduction. Cool, so here we go. So we're going to start on the anterior teeth. We've already finished the left side. I'm not going to show you every prep because we'd be here all night. But we'll do the anteriors together real quick, and then we'll do S, and then we'll get this case completed start to finish. So I like to use a football burr, or sorry, not a football, excuse me, a donut burr to do my incisal and my occlusal reduction. This makes it really quick, really efficient. I can get through these incisal reductions in about 30 seconds, and then we're moving on to the bulk of the prep here. So cut our incisal edges down. This is a normal presentation. We don't have any wear, anything strange going on with this kiddo. So she's just your typical 1 to 1.5 millimeters of incisal reduction. And this is our pointy, thicker diamond burr. So the tip comes to a point, but you can see as it gets closer to the thicker part of the burr, we've got some more thickness to that diamond, so I can do a little bit more simple reduction. So we'll take that burr there, and you'll see I start interproximally, and I'm aiming for the tip of my burr to come out just below the height of contour, so I get all of that bulk off the tooth in one fell swoop. So we're going to hit the distal there. We're going to take it all the way in, and you can see I'm starting in deep in the tooth. I'm creating a little bit of a trough for my burr to follow so that it doesn't kick off to the side and hit the adjacent tooth. And then we're just going to flatten that off and get all the way down to underneath the height of contour there. We're going to do the same thing on our central incisor. That distal sticks out a little bit further, so you can be a little bit more aggressive on the distal. You see how I have like a little wall of enamel there? If you're doing a single tooth and you don't want to hit the adjacent tooth, that's a really good way to prevent that, is leave a little thin wall of enamel as your burr goes through. And as long as you can see that wall of enamel, you know you're not going to hit the adjacent tooth. I do that a lot on the distals of E's so that we can avoid sixes as well. So it's a little trick just to give you some more confidence when you're prepping against a tooth you're not going to restore. So we'll get rid of that entire height of contour, all that convexity. Those are our interproximal preps. We're done with the interproximal. Now, because we've gotten subgingival interproximally, I can dip the tip of my burr into the sulcus much easier without creating much trauma. So you see how I've gotten into the sulcus and we're not destroying the gingiva, we're not tearing it up, we're not creating a ton of bleeding. We're going to create some, but we're going to try to limit that as much as we can. And so now I'm going to really aggressively cut down about 1 millimeter to 1.5 millimeters here circumferentially, but keeping the burr tight to the tooth so that we don't create trauma to the gingiva anywhere. And at this stage, I can just go around the tooth. As long as I'm keeping the burr in contact with it, I know I'm not getting off track and I'm not creating trauma. So I'm not really using my mirror at this stage. I'm just creating a little bit of a trough in the sulcus so that when I go to seat that crown, it seats within the sulcus just how it should. And that's how you get that really nice tissue response as well. And as we go, just round little point angles and line angles. You want to keep everything round, no sharp stuff if you can avoid it. So there's our central incisor. I'm going to show you here, this is how I get rid of the cingulum. So I do use my mirror for this part, and then I'll lean the burr into the tooth. So when we do the workshops, we talk about using the football down in this area. This is what I do, is that once I've created that little trough, now I'm going to lean my burr into that sulcus. So if my sulcus is sticking out like this, I'm leaning my burr into it and just flattening that cingulum off, getting rid of it completely. And as we go, we're going to round into the interproximal. So those line angles that are created from lingual to mesial or lingual to distal, we want to round into those to keep everything nice and smooth. Here's my lateral. We're going to do the same thing here. We won't belabor this one too much because it's kind of the same thing as the central. So one thing here is we're going to see that there's still some decay left on that deeper portion of D on the facial. And so we'll go back and we'll address that later on. So once we finish the prep, I'll go back with a slow speed round burr or something like that. We'll excavate that big stuff out. And then, if we do a pulpotomy, well, then we'll do it at that stage. Or if we're doing an indirect pulp cap, we'll do it at that stage as well. So same exact thing there. We'll skip that because it's the same thing we did on the central. And there's our cingulum again. Same idea. You can see this a little bit better, how I'm leaning the burr into the cingulum a little bit in my mirror there. But same exact process. We're just going to lean into the cingulum, flatten it off. And then when you go to do your try-on, if you put your try-on crown in and it's still hidden, then yeah, go back and do another adjustment. No big deal. But this will get the bulk of it done for you. So here are our preps. We won't show you the other two because it's the same as the first two. But these are what our preps look like. Looking at this too on E or 5-1, I would have probably gone back and rounded that distal point angle a little bit. So you can see the difference between E and F, how that F is a little bit more rounded and E isn't. Maybe even D as well. If we're being extra picky, round everything even a little bit more than I did there. So here's our posterior. We'll work through this one as well. And for those of you who are wondering how big these occlusals were, the L was about the same, just wasn't quite as deep. But you'll see once we do this incisal or occlusal reduction, you'll see how big this occlusal cavity was. And you'll see kind of why I opted to go with a crown versus a composite restoration. But it's the same exact thing. I'm cutting down into the about to where the central groove is. If I wasn't going to be opening this pulp up, I would take that burr and I would lean it on the lingual like this, and I would lean it on the buccal like this to create my central groove again. And we've already finished the pulpotomy. I won't go into that. Dr. Ruck did a fantastic lecture on that about a month or so ago, so I won't try to outdo him because his was perfect. But that's my pulpotomy. I have neo liner on top of the neo putty there. That's what's keeping everything in. But I take that same burr that I used on the anteriors, and I'm going to picture the same exact scenario. I'm trying to get rid of that height of contour, that convexity of the distal. Same thing on the mesial. You'll see how I create that little bit of a slice there, that little cut, and that's what my burr is going to follow all the way through. And that way I don't slip off to the side. So if you create a little notch where you want your slice to begin, it's much easier to follow along rather than worry about your burr kicking off one way or the other. And now that we've created that, we've gotten into the sulcus a little bit without creating any trauma. And now I can follow the sulcus the rest of the way around the tooth without damaging the gingiva too much and creating too much bleeding. So you'll see how I just follow the sulcus around, and as I reduce a little bit more, I can dip the burr into it a little bit further. And that little buccal bulge, I'm going to pay a little bit more attention to because I need to get rid of that bulk.
10-minute warning, Dr. Lucero.
Thank you. I think I'm going to make it tonight. I'm terrible at keeping time, so Last time I was way over. I have a whole story about a foster dog that was screaming in the background too, but I won't bore you with that tonight. But anyway, so yeah, that's what we want to do. We want to dip the burr. So we're starting in proximally. We haven't created trauma, and we're going to use that burr to follow the sulcus all the way around 360 degrees. And now we're going to do the lingual. And this is tough. This is a GA case, so this makes it look like a piece of cake. But if you have a patient with nitrous or oral sedation, this is the area where things get really tricky on the mandible, especially, and with ease, especially too, is fighting the tongue and creating enough space for your handpiece to make it around the lingual. That's not easy. My suggestion is if you're still in the early stages of doing zirconia, try a first molar first. Just do one, see how it goes, and then if things go smoothly, then go to your ease. Or do it for a GA case like this one is. But those are difficult. It's difficult to get your handpiece back there, and it's difficult to create enough space. So that's my prep right there. I'm going to spend a little bit more time on the buckle, get rid of all that bulk there. You see how I've created that nice little trough. You can see on the lingual really, really nicely where that trough is and where we can get the crown to slide in when we go to cement. So we're going to go back to the anterior really quickly. Remember I talked to you about number D. We used our slow speed handpiece. We're down to affected dentin, right? Affected, not infected. We want to get down to the leathery, firm stuff. And this also helps for any shadowing that may show through as well, because zirconia, we talked about it as being translucent. Any kind of staining, SDF or any of those types of things, if you have concerns that you might get a shadow showing through it, you can do an indirect pulp cap with neoliner, or if you have another material, just something to block it out so you don't get that shadow showing through the zirconia potentially. Doesn't always happen, but if you want to alleviate that completely, do a quick little indirect pulp cap like that. So now we're gonna do our tri-ang crowns. These are the pink tri-ang crowns. Some people question how important these are. I love tri-ang crowns. Zirconia gets contaminated and you lose some bond strength because of blood and saliva getting on the intaglio. It also makes it a whole lot easier. Your assistants don't have to clean this blood out before you cement. So you get these ones really messy, these pink crowns. You try them on. You want to make sure they're a little bit passive. So you'll see, I'll take my fingers. I think I might have already done it. I wasn't watching. We'll play it one more time. But you see, I try them in, and watch right here. I'll take my fingers and I'll just make sure that these crowns rotate just a little bit. So right there. And all I'm doing is checking for passivity. I just want them to rotate just a tiny, tiny bit so I know that I'm fully passive. And then we'll try the rest on there. But the nice thing about tri-ang crowns is once these are bloody, I hand these to my assistant. She sets them aside and she'll take white ones that are the exact same size and immediately load those up with cement. So there's no cleanup before I cement. Makes things a little bit quicker. Typically, I'll do centrals before laterals. I'll stop the bleeding with local anesthesia. That's why you see the gingiva's kind of blanched and white there. But you can see how it slows down the bleeding pretty well. All you need to do is beat the blood to the tooth. That's something Dave Evans told me a long time ago, and it always sticks in my head. Just beat the blood to the tooth, and then you're fine. All these cements are thick enough that they're going to displace any blood that tends to seep out after the fact. So as long as you're there first, you're good. So I'll take usually my centrals, my assistant, of course, when I'm recording, they handed me the laterals. So we're going to do laterals first. You'll see I get a nice little collar of cement, squirts a little blood out, no big deal. It's not going to get underneath the cement. You want that collar there because when we go to cure or tack cure, you're going to be able to peel that off much more easily than if you have a really thin, almost invisible layer of cement. So you'll see here, she'll tack cure these, depending on your light strength, maybe 3 seconds, might be 5 seconds, whatever your light does, test it out beforehand. But I'll go in there, I'll have her tack cure these in place, and then I'll keep finger pressure, keep my finger on the incisal ledge so it doesn't move, and then I can pop that cement off super, super easily. So if you actually have a decent amount of excess, it cleans up much more easily than if you have a really thin layer. So we'll do that, clean up both of those, make sure our bleeding stops one more time, and then we'll do our centrals. Because that excess squirts in proximal, you have to clean up first. I don't like doing all 4 because it's really, really hard to manage 4 crowns at the same time. So that's when you'll start getting cants and rotations and all kinds of funky stuff. So I tend to do 2 at a time. Again, I usually do my centrals first, but when you record, that's when everything goes wonky. One thing I want to point out here really quickly, I'll play this one more time, is I didn't get these crowns exactly where I wanted them to begin with. And so you'll see me take my Explorer. When these crowns get canted, what people tend to do is try to push them back into place. That doesn't always work. So you can see I got a little bit of a cant to the distal. I don't like how it's seating on E. So I'll take the tip of my Explorer, and rather than push the mesial, I'll lift the distal. And that way you can get that crown to kind of upright for you. Same thing here, maybe a little more excess than necessary, but you can see how easily it pops off. Same thing on the lingual here. I try to pull the interproximal out. That way we don't need to floss quite as much because I don't want to displace these crowns. Then we'll do a final cure after that. She'll do 10 seconds facial, 10 seconds lingual. And we'll do the same exact thing for our molar. For number S, we're going to fill that. I probably would have liked a little more cement than that, to be honest with you. Then we'll go and do our local, blanch that tissue. I'll fill up the remainder of my pulp chamber with some cement. That way we have no voids. And then we'll seed our crown, and we'll go through that exact same process. We won't show you the whole process because we just talked about it. But that's the exact same process for the posterior. One thing to keep in mind for posterior is make sure you have enough room to get the light in there. When I first started doing these, I had my finger over the crown. I had a little bit of blood coming up over the top. My assistant went back to cure, and then when I went to remove my fingers, the crown floated up off of the tooth, and then everything got contaminated. So make sure you have plenty of space, and make sure that light can directly hit the crown without covering it or shadowing it with your fingers or blood or anything like that. So keep that in mind. And here's our finished product. Here's the finished case. We can see our occlusions back to where it was. And I'll show you the pre-op and post-op side by side so you can see. But the key with these when you're doing posterior is getting the same occlusal scheme. You don't want to end up in hyperocclusion if you can avoid it. That's why we stress so much about the occlusal reduction with zirconia. So here's the pre and post-op. You can see our occlusions pretty much back to where it started, and you can kind of tell by the canines, that space between the canines there. It's about the same at the end as it was when we started. And then here's an incisal view, and then a little bit better view of those posteriors. But you can see how things are kind of emerging up out of the sulcus, like an emergence profile. You know, if you remember that fact from dental school, you want a nice emergence profile. You want everything to come nice and gently out of the tissue. Here's our post-op radiographs. You can see zirconia is super, super radio opaque, so you're not going to be able to see much underneath. Occasionally, you can see a pulpotomy on anterior. Sometimes you can't. But you want that to fit the contour of the tooth as it was before, right? You can see we don't have really big overhangs. You want to be especially careful on E's so you don't create ectopic eruption of your sixes later on. So all these things are important, really making sure that you've got your sizing dialed in when you start. Here's a post-op radiograph. That's the same one as I showed you on the previous slide, but I superimposed the pre-op over the top so you can kind of see how we started and how we finished, how we kept things, you know, the occlusal plane as close to normal as I could keep it, and then keeping the contour of the tooth about where it was when we started. So here's some final tips. I think we might make it on time tonight and have some time for questions. Number one, create your game plan for hemostasis. And that means prepping with a purpose, understanding like how to avoid trauma the best that you can so that you don't have as much to take care of later on. Using radiographs to visualize the anatomy and your endpoint to achieve a passive fit. So picturing, okay, here's my height of contour. Here's where I want to drop through. That's where I want the tip of my burr. I want to slice this off. These are where my pulp horns are. All of those things. This is where my occlusal plane is. And when I do my try-in crown, how I can get that back to where the occlusal plane was, or using the adjacent teeth as a guide. So all of those things are meant to envision recreating what was there originally, right? We want to recreate biology the best we can. If crowns aren't seating, reduce circumferentially in the gingival third, not the incisal third. Don't lean the tooth in, narrow the tooth down here. Only pulp if the caries dictates it. We don't have to pulp if we're just doing a zirconia, that we shouldn't have to unless there's decay telling us that we should. Using a slight bit of excess to avoid internal voids, and for simple cleanup, you can see how easy that stuff popped off. Seat and adjust your alignment before tack curing. And this is where, take your time. I've got plenty of examples of me cementing a crown and I take my finger off and it's like this because I didn't take my time and I didn't, make sure everything was perfect before I tack cured. Once we tack cure, we can't go back. We've already polymerized the resin and we can't go back and adjust it. So take your time at that stage. You got a minute and a half, 2 minutes of working time. You don't need to rush through that. If you need to take the tip of your Explorer to change the orientation of your crown, go for it. And then prepare guardians. I think this is a big one. Even when we master these things, especially when we master it, we start thinking that we're like infallible and we can do everything. So you need to keep in the back of your mind that not every case is going to be a zirconia case. If you have space loss, if you have crowding, if you have rotations, overlap, anything like that can prevent you from being able to seat back-to-back zirconias. So always be mindful of that and make sure that when you're telling parents that you can do white crowns or aesthetic crowns, that there's a chance you might have to do stainless steel if it becomes necessary. And so make sure they're okay with that before you get stuck. And that's it. That's it for tonight. I think hopefully we became as masterful as we can be in 45 minutes. But if you want to become more masterful, we've got lots of workshops coming up. I'm actually leading Los Angeles and Newburgh, which I'm super excited about. Newburgh, like I mentioned, lots of Pinot, so we can have a little bit of wine in Newburgh. Fort Lauderdale is going to be awesome. That's where I went to dental school. That was that terrible picture I showed you. In Boston in December. So if you guys want to come and hang out with us for the weekend, it's a good time, and hopefully you'll learn lots of important info. And then that's my info. Thanks y'all for listening to me. Hopefully that was beneficial. But if you want to ask any questions, you can email me. And like I said, if you want to see some cases every now and then, you can follow me on Instagram.
Thank you so much for that, Dr. Lucero. That was perfectly timed.
No, I'm amazed.
So we'll go ahead and open it up for questions now. Feel free to drop any questions that you have in the chat, and we'll do our best to answer as many as we can. If we don't get to your question today, someone from our team will be reaching out to you through email, and we'll make sure to get your questions answered offline. We do have a couple of questions already, so I'll go ahead and read them out to you, Dr. Lucero. You mentioned pulpotomy for anterior. I've only done pulpectomy for anterior if needed. How has your success rate with pulpotomy for any been? I would love to switch.
Great question. So I actually was reading the guidelines recently, like refreshing myself because it's very easy to like get lazy and not read them. So I went back and read them, and there's a whole new section on pulp therapy. And this is what I've always done pulpotomies, not because I'm a genius, that's just what I was taught. So I went back and I read the guidelines, and the guidelines now support anterior pulpotomies versus pulpectomies. Unless there's, a necrotic pulp or anything like that, then obviously pulpectomy. But the research now supports doing pulpotomies, and it's leaning more towards doing MTA or biodentine versus doing formicrosol. So I've always been a pulpotomy guy. I know there's lots of my friends and lots of colleagues who do pulpectomies because that's just how they were trained. But I've had very good success. I've gone from formo, I've done formo in the past, and I've done MTA, and that's what I currently try to do mostly. But I've had good success with both. So I would say the one thing that people tend to get nervous about with pulpotomies is like they don't know where to end, right? You open up the pulp on an anterior, and posterior you can go down to the orifices and you're done. Whereas an anterior, you drop your burr down and you could keep dropping it down until you hit the apex. So what I tend to do is try to aim the tip of my burr for about the CEJ. And that's where my endpoint is. So I'll work it around all the way around the CEJ there, try to clean all of that coronal pulp out. Then I'll get my hemostasis, then I'll place my MTA. So that's my process, and I've had very good success with it. Of course, I've had failures, and they're not perfect, but it does work very well.
Okay, the same person asked a follow-up question. So if you cemented 4 together and got a cant, and tried to fix it but couldn't fix it, would you consider drilling off the crown to redo?
Yeah, it depends on how egregious it is. Like, if it's a little bit of a cant and it's not, terrible, then, you just move on and try to do better the next time. But, I always keep in mind that like that kid is one of one to those parents, right? Like, to me, it's one of 8 or 10 or whatever that I did that day or 1 to 100 that month. But to those parents, like that's their kid, and that's what they're going to have to look at until that tooth exfoliates. So that's why I'm extra careful, and I try to do 2 at a time, because if you try to do 4, there's a lot of moving pieces going on, and crowns tend to want to rise up or float up off the tooth. And if you're not holding them, well, then they start moving. Or if you're covering them with your fingertips, it's hard to see the incisal edge. And so for me, 2 at a time is easier. So you can take a fine diamond and kind of flatten off, if there's a cant like this, you can try to flatten off this little thing and level it back out. It doesn't always work perfectly. I've done that on occasion for like little adjustments, but cutting it off, especially if you're in GA and you have the time, it stinks. It's no fun. But sometimes that's the best option.
All right, next question. How do you handle class 3 patients and cross bites?
Very good question. That was one I considered doing for this one, but it's such it's not as typical, so I didn't go into that. But Dr. Evans, I keep mentioning that guy because he's who I learned everything from. But his way of doing it is, say you have a crossbite here. So here's your lower incisor, here's your upper incisor. You have 2 side by side. You have E and F or D through G or whatever you're doing. So prep one of them, and then try your try-in crown on without prepping the other one. Make sure that your bite goes back to where you started. If it didn't, then do a little more facial reduction and then try it again. Once things match up and you get the occlusion back to where you started, now you cement that one, and then that's your guide for the next tooth. So then you prep the next one, make sure you get back to your start point, and then you cement that one. So it takes a little bit longer and it's a little more tedious, but unless you're trying to correct a crossbite, which I try not to do that if I can. If you're going to keep it in a crossbite, that's the best way to keep things where they were.
All right, thank you. Next question. Any cement you recommend for those parents who are anti-fluoride?
Yeah, I know. I don't have an answer for that. My friend Jen, Dr. Jen, she I think has more patients that request that type of thing. I will ask her or ask her. She's on Instagram too, so she's the baby tooth dentist. So she has lots of patients I think that are more along that line of thinking. So she probably would have a better answer for you than I would because all the cements I use have fluoride in them. So I don't have a good answer for you. I'm sorry. And if
Yeah,
anyone has an answer, chime in the comments real quick and we can read it out.
yeah, I think she'd be a great resource for that question. Um, Here's another question. How do you compare anterior zirconia prep to new smile signature prep? Would you say it's the same?
Very good question. It's fair. It's very similar. You might be able to get away with a little bit less with the signature crown, and you can get away with it fitting tight too. Like if you want to seat a signature crown and not have it passive, you can do that. So you can probably get away with a little bit less reduction. But in all honesty, my preps are pretty much the same. I do a ton of signature too. I'm not exclusively zirconia. That's probably like I probably do like 15% zirconia, 20% zirconia. The vast majority of my kiddos are signatures. So I do those same preps all the time, and it's pretty much the same thing.
Do you have any tips for prepping a canine?
Yes. So the reduction's exactly the same. The difference is because a canine doesn't have a flat incisal edge, that curvature, you want to follow the curvature of the incisal edge when you do your reduction. You don't want to, you can flatten it, I guess, if you want, but ideally you want to keep that curvature a little bit. Same exact interproximal slices. The cingulum's much, much bigger. So you're going to hack off a lot more cingulum than you will for a central or a lateral. And then the one spot where everyone runs into trouble because you lose sight of your burr is the distal lingual. So when you're wrapping around the distal to the lingual, that's your blind spot. It doesn't matter if you're on the right or left. If you're right-handed, left-handed, doesn't matter. The distal lingual is the spot where you lose sight of that burr. So when people end up under reduced, it's almost always there. So be very, very mindful of checking that distal lingual and making sure that you're reduced enough in that area.
All right, here's
With
another
signature counts,
question.
like we just talked about, same exact thing with signature. So distal lingual always, or almost always.
Next question. How do you ensure that there's good alignment on all four anterior crowns prior to cementation?
Good question. Yes. So what I do is I mentioned using like the pad of my finger. I don't do that anymore because if you see like the pad of your finger can indent a little bit, and so you can kind of mask where your crown is angled if you're covering up that incisal edge. So what I do now is I take the tips of my fingernails and I'll hold the tips of my incisal or I'll hold the tips of my fingernails against the incisal edge. That way I can view the entire crown and I can see any cants on the incisal edge. The other difficult part is when you get a lot of cement that comes out from the sulcus when you seat them. Sometimes that can cover up your line angles and mask cants as well. So occasionally I'll wipe off a little bit of cement if it's interproximal in the embrasure a little bit, and that way I can see the crown better. But really just making sure you're not covering the crown with your finger. That's how you can visualize things better.
All right, it looks like we have time for a few more questions. Here's another good one. Will leaving effective dentin show up on an anterior zirconia crowns? And are there any differences in indications between signature and new smell signature crowns and anterior zirconia?
Yeah. So the first half about staining, yeah, you can theoretically see staining through. With like SDF staining, you could theoretically see that. I don't have that happen that much because SDF doesn't penetrate that deep. So usually with your regular reduction, you'll get rid of a lot of that staining. But if you have areas like I showed in the case earlier where you have some darker dentin, or if you're going to do an indirect pulp cap anyway, then you can place something like a neoliner or any other indirect pulp capping material you like, and that'll opaque that out enough to where you're not going to see it through the crown. But usually you don't. I mean, zirconia is translucent, but it's not see-through. So you may see some really really dark stuff show through, but you won't see everything. You won't see every little detail every time. And then regarding signature, really with signature, for a lot of people who, especially if you see a lot of Medicaid patients, a lot of Medicaid plans only cover signature crowns. They don't cover zirconia. So that's one reason why you may lean towards signature. The other is it's less expensive, of course, so it doesn't cost patients as much. Some downsides to signature that I've, over the course of lots of years have learned is, especially you folks that are in hospitals and you see a lot of special needs patients, patients that are getting a lot of imaging frequently, you can get some more artifact in those images if you have the metal substructure on a signature. So sometimes zirconia is a better option for kiddos like that. Obviously very, very rare nickel allergy. It's super rare, but you may want to change your plans with the signature for kids like that. But really, I mean, it ultimately comes down to aesthetics. Like signatures are lifelike, but they're not nearly as pretty as a zirconia is. So that's usually the criteria is, how aesthetic do you want this crown to be?
A follow-up question to that is what if there is bleeding under the crown when cemented? Will there be staining or will the crown come off in the future?
Potentially both, and they don't usually come off unless you have some really significant blood or saliva underneath contamination. You will get staining though, like almost certainly. Like if you have blood underneath and it's usually going to get really dark. It's not going to look red. It's going to look almost like brown or black. So I would say, the bleeding is really important for both of those. But aesthetically, especially if it's on the facial, of course, you're going to see that pretty easily. So really, bleeding control and isolation is, really, really critical for these crowns for both those reasons, but especially for aesthetics.
All right, we have a few more minutes left. Here's another question. Do these crowns come off during function or trauma, etc.?
Trauma, I've hit, Dave Evans again. I keep mentioning this guy. He must be important, but he has a case where a kid got that. Actually, that tooth I was showing you that had the full root attached to it when I was walking through the steps of the prep. That was an avulsed tooth that was one of his patients. So trauma usually doesn't knock the crown off. It knocks the entire tooth off it knocks the entire tooth out because the cements that we're using are so strong now. Like Biosem's super strong. Those RMGIs are super strong. Sometimes the crowns come off, not that frequently, but if a kid takes a big enough blow, you'll avulse the entire tooth before you'll lose the crown sometimes. And what was this? What was the second question? I forgot the second half of that one. I'm sorry.
Function or trauma?
Oh, function too. Yeah, I mean, unless you have like some really, really serious interferences, which you can have, especially like those crossbite patients that we talked about a second ago, or if you really, if a kid's not an end-to-end occlusion and you put them end-to-end, you're going to end up with trauma. You may not lose the crown, but you're going to have some significant occlusal issues. So you may not lose the crown, but that's something you definitely want to try to avoid either way.
All right, here's another question. Do you have any? Oh, we already answered that one. Let me just go down the list. Any tips on fixing the prep to ensure proper alignment of the anterior crowns?
Yeah, I mean, just keeping your burr vertical or parallel with the tooth or with the long axis of the tooth. That's the main thing. You're never going to go wrong doing that. Like you may like if you want to flare a tooth or if you want to tip a tooth back or if you want to adjust things like that, you can change the angulation of your burr to make those adjustments to a limit to a certain extent. But in general, most of our kiddos, if we're trying to recreate what was there already, just keep your burr parallel with the long axis of the tooth because no matter what, you're going to have that path of insertion that's going to follow the way the tooth was to begin with. But sometimes you'll get these really flared kids and you're trying to pull them back in, or you'll get a kid who's end to end and you're trying to get them, into normal overjet. And so you can angle the burrs in certain ways to change that, but there's a limit to how much you can do.